planning TAVR. I think it's a very important step. We give a lot of time for initial planning and I think we discussed this, but I'm not going to go more in detail. But it's very important to have a proper assessment of the patient and assess the STS score and Euro score. That's very crucial at this point. Even legally, before we do a TAVR, the patient should be either have intermediate risk or high risk. So if they have a low risk STS score less than 4, then this patient should go for surgery. So that's very important. So we have to make sure the STS scores are right. And then initial assessment, we know echocardiogram, we dealt with in detail. I think Professor Alagation had a detailed lecture on echo. So we're very important. We know what we are looking for in the echo. We know we may confirm the diagnosis, and also we have to certainly look at debutant echo when we have a doubtful diagnosis. And I don't have to give, the most important thing is the symptoms of the patient, and that is also, the patient should be symptomatic before we proceed with the treatment. And the CT, I think Dr. Ravindra Rao dealt with in detail, but again, CT is the most important investigation before we proceed with TAVR. So we get all the information from the CT. So CT is the only test which will give all the information. And essentially, we look at the valve and we look at the annulus. All the important measurements are done from the CT. Also, we look at the groin, look at the iliofemorals, entire vascular tree, and also we look at the coronaries. So again, practice differs. In my practice, I assess the CT by coronary, and most of the time, if the coronary CTs, if coronaries are normal, I don't proceed with a regular coronary angiogram. And some of them go ahead and do a coronary angiogram also. But if I find significant coronary disease, I do a coronary angiogram. A very, very valid point, Dr. Madhavan. That's why if you have a doubt, if there is extensive calcium, if there is some suggestion of disease, I would definitely urge to do a coronary conventional catheter coronary angiogram. Because now we are moving to a situation where unless you have a left main disease or a proximal LAD disease, or if the patient is having ACS, we don't tend to intervene the coronary. Even if we find, for example, a right coronary artery lesion, we just perform the TAVR, and then if it's an asymptomatic patient with the right coronary artery, even if it's 80-90% lesion, we are not keen to intervene that immediately. So that's again subject to individual patient. But general principle is if we have a proximal LAD, left main or ACS situation, we intervene that. So that's the first step. And the next planning TAVR. Again, I want to emphasize the importance of heart team. I think Dr. Muthu will be talking in the next next lecture. So it's very important to have a very detailed discussion with the cardiac surgeon, the anesthetist, the imaging specialist, echocardiographer. So we have a very good heart team in our hospital, and we discuss. And now we know that surgeons have a lot of reluctance. They want to take most of the patients for surgery, but now they understand the importance of STS score. They understand the risks involved, and if they are able to see the results of the TAVR. So the acceptance of surgeons is now better. So we have better interaction during our heart team meeting. So next is anesthesia. Again, is very important because our anesthetist, again, there is a small learning curve in that, because initially we were comfortable doing general anesthesia. So fortunate to my short period of stay in France, where I observed that they all do a less invasive TAVI, where they do most of the procedures for local anesthesia. So even from our first patient, we were more towards doing in a less invasive way with local anesthesia. So we sometimes use a mild sedation, and I think Dr. Ganapathy from our anesthetic team will be sharing our experience on less invasive TAVR. So again, we look into many factors, whether the patient will be able to lie down for 1.5 hours comfortably, and whether we are going to have a complex procedure where we would, in such situation, we would do a general anesthesia. So sometimes even the need for TE, transesophageal echo, that is also important. Suppose we think that TE is required, then sometimes in huge calcific valves, or we want to see, sometimes we can even see whether there is even the patients at high risk with LVOT calcium, then the risk for annular rupture. In such patients, TE monitoring will be very helpful. So we do consider, when we think the TE is required, then we definitely consider general anesthesia. So the other thing is a lab. The cath lab, ideally, what was recommended earlier was a hybrid lab, but nowadays we are comfortable with our regular setting, but the lab should be adequately large. We need a good space to prepare the valve, because there is a large table required where the valve has to be prepared. So should be a significantly large place, and capabilities for a transesophageal, and we also keep the cardiopulmonary bypass, and the surgeon is ready to go on pump if required. So that we always do that. And also we keep the vascular team on standby. for in case we need to do a cut down. But most of the time we do percutaneously using ProGlides, but then most of the time we always have the vascular team on standby. So that's about the preparation. So let's move to the next step. Can I have the slides? Yeah. Okay, now once we decide on the anesthesia and all that, and now we have to decide on the vascular access. The trend today is to do more and more through transfemoral approach. And even in our experience, almost our 100% we were doing femoral. So earlier it is just a shift, it gradually, now the transapical is almost gone. So trans-aortic is coming down. So other alternative approaches has to be considered if the femorals are not suitable, like subclavian or now even elegant transcaval. There has been procedures documented where the femorals are inadequate or very small or diseased. Then they go to inferior vena cava and puncture the aorta, the abdominal aorta, and then perform the TAVI from the IVC to the aorta, and then they close with the amplifier device after the procedure. It's been elegantly done. So that's again new things which will probably evolve even in our country soon. So pacing, now I generally use, you know that pacing is a very important aspect of the TAVR, where we may have to do a rapid pacing during valve implantation, particularly during balloon-expandable valves. So we use always a balloon-tipped pacemaker, and our general goal, we keep a femoral access and keep it in all balloon-expandable valves. We keep the pacemaker through the groin. It's simple because for balloon-expandable valves, we can remove the pacemaker immediately after the procedure. Like in Edward sapien valve, we immediately after the procedure, we get no need for pacing for longer. So once there is no heart blocks, we remove the pacemaker immediately. So we always keep the femoral vein access, and for core valve and evolutar, our practice is to keep it through the internal jugular vein, because we generally keep the pacemaker for 24 to 48 hours after the procedure, and these patients can often be mobile when you have a pacemaker through the neck. So that's the reason. So the principal access site is again chosen depending on the CT findings, depending on the size of the femorals. The three things: size, tortuosity, and calcium. So based on that, we decide whichever the right or the left femoral. And once we decide on the principal access site, usually we puncture. I will talk about the puncture in the next few slides. So once we put in after puncture, we put a 6 French sheath in, and then use ProGlides. And generally now we use 2 ProGlides for this. Our procedures, which are usually about 14 French or sometimes 18 French. So we use 2 ProGlides, and once we place the ProGlides, we keep 8 French sheath, and then we slowly upsize it to 14 French sheath for valve delivery. So that is on the principal groin. The other side, we put in a 7 French sheath, regular puncture, put a 7 French sheath. This is for keeping the pigtail in the non-coronary sinus. That will help us to position the valve. So we keep a pigtail through the other groin. Purposefully we keep 7 French, because by using a 7 French, through the side port we have the arterial line. So we don't want an additional arterial line from the radial or from the another from the neck. So we want to minimize. See, that's why we call it as a less invasive TAVI. So we want to minimize the line. So we just have 2 lines. One line will have 7 French, and the side port will measure the pressure. So heparin, again we use heparin, but we give before we do the ProGlides. And just before we introduce the large big sheath, we give the heparin. So until then we don't give. And finally after we suture the ProGlide, we again reverse the heparin before we give a small pressure and close the groin. So puncture techniques. So there are a number of ways one can puncture. Though initially we started. Can you click on the image? So what we have done, we use a pigtail, and pigtail serves as a marker. Pigtail serves a marker, and we can puncture exactly at the center of the circle, where we are very sure that we are doing anterior puncture. We are sure that we are just in the center of the artery. So that's one way of puncturing. That's how we started doing most of our cases. But of late, what we have learned now is to use ultrasound guidance. Again, it is much more easier, and also we don't have to have hand radiation when we do ultrasound. So we have just done the last 3 cases. We have done ultrasound, and we are finding it more useful using ultrasound guided puncture. And others sometimes even use wire, just simple wire marker as a mark. So generally we puncture. One of the important criteria is we make sure we look at the bifurcation, and we want to be well above the bifurcation. The idea is mainly if you have a problem, we don't want when we want to put a covered stent, for example, we want to make sure we don't come across, involve the bifurcation. So that is the whole idea of puncturing just above the bifurcation. So the next important step is to have a good implanter's view. So implanter's view can be even during the CT, they will give you information on which is the best view to have all the three cuffs in one plane. Again, it's very important to position the valve in that plane. So all the three cuffs will be in one plane. So the CT will definitely give us a view, so which we can use it. But that sometimes you have to do a slight modification. And usually we follow the right coronary rule. So what we do is, if you can see the diagram below, so you can see that there is a pigtail which is kept in the right coronary artery. I think you have to change it to my laptop, it's not playing, yeah. So we keep a pigtail in the right coronary artery. And what happens is, if the pigtail is towards the right, then we move to a RAO. If it is a left, we do a LAO. And you can see in the other picture, if the right coronary pigtail is high, then you do a cranial. If the right coronary pigtail is low, then you do a caudal. So it's simply doing these maneuvers. It's called right coronary rule, which really helps. It helps to get into the same plane. If you click on the image, you can see now that we have aligned it in the three cusps are in the same plane. You can see that all the three cusps on the same plane. Can you click on it again? So you can see that all the three planes are on the same plane. All the three cusps, the sinuses on the same plane. The other way is removing parallax is using the marker from the evolute TAVR catheter, which I will show you as we go on. Next slide. So the next step is to cross the aortic valve. So through the primary principal groin. Then once the big sheath is inserted, one can either use a AL1 catheter or a JR catheter, depending upon one's preference. We usually use a AL1 catheter with a straight tipped 035 wire. Then you have to do a slow maneuver slightly, keep doing anticoagulation rotation, and then keep moving the wire up and down. Then you can easily cross the aortic valve. We can also use the iotogram and look at the jet to know where exactly to point the wire. So once you cross the aortic valve, then we push the Amplatz L1 inside, and then we use a regular wire and pass the regular wire, and then move to a pigtail. And with the pigtail, we use a pigtail, and then we use the LV wire. After we pass the pigtail, then we pass the LV wire, a curved LV wire. So using the choice of LV wire again is it depends on the operator. We generally try to use the dedicated wires. There are some dedicated wires, Confida wire or Safari wire. The Confida wire from the Medtronic, it's a soft tip, it's already pre-shaped, so it won't hurt the LV. The other options are you can use Amplatz extra stiff wire, you can manually shape it and use it, but you have to be extremely careful because the LV rupture is again a major complication if a wire is not properly shaped and properly positioned. So there are other wires like Safari wire from Boston, which can also be helpful. Again, there are different sizes, small and large, depending on the size of the LV. And Lundquist wire is again an extra support wire. When you have very tortuous aorta or a difficult anatomy, Lundquist wire may be really helpful in such situations. So once we make sure we place the wire in the ventricle, and the transition point should be above the apex. That's again important. And while manipulation, there should not be any movement of the wire and causing a trauma to the LV. So also one should be sure that it is not catching on the cardia and the wire should be free before we pass the balloon. So once we know that, then we have to decide on the valve. Again, we look into many factors like the LV function, the amount of calcium, whether it's a bicuspid or tricuspid, the LVOT calcium. Again, that point I would like to stress, because if there is a calcium extending into left ventricular outflow tract, in such situations, there may be a slightly higher risk with balloon-expandable valves. So self-expanding valves are much safer because you don't aggressively dilate. So balloon-expandable valves are better avoided when there is extensive LVOT calcium. LV function, you have a very poor LV, then you want to avoid rapid pacing. So if you want to use rapid pacing, for balloon-expandable valves, you have to use rapid pacing. For self-expanding valves, you can manage without rapid pacing as well. So if you have a severe LV dysfunction, then we tend to choose a self-expanding valve. So other than that, we look at the diameters. For most of these valves now are more than 5 millimeters, above 5 millimeters in the femoral arteries. You can take but in self-expanding valves, we have it's a slow deployment. We have the time, we slowly deploy. So we don't have, sometimes we use a slow pacing, sometimes we don't even use pacing. It depends. But in balloon expandable valves, it's quite a rapid inflation and deflation, and one needs to always use a rapid pacing. So again, a tip on the measurement, we measure the size of the valve based on the perimeter for self-expanding valves. Perimeter is a measurement of the entire circumference, whereas for balloon expandable valves, it's area-based diameter. So we derive the diameter of the annulus based on the area. So next step is balloon-aided plasty. I think that now there is a trend towards doing a direct implantation, but as a general practice, we always do a balloon dilatation. In most of the situations, unless you have poor LV, we don't want to give multiple pacing, then we do, and minimally calcified valve, then we do a direct implantation. And definitely in situations where there is a bicuspid aortic valve or there is severe calcification, one must definitely consider doing a pre-dilatation. So appropriate position, projection, and make sure the balloon is kept at the annular level. So balloon sizing, again, use the CT dimension, CT diameter, look at the minimum diameter, just up to the minimum diameter is safe, sometimes even undersize it by 1 millimeter, and then we can increase it up to the minimum diameter. The maximum we can go is up to the mean diameter. So the general sequences, do a pacing, and it's very important to do pacing for balloon inflation. Pace, inflate, check, deflate, stop pacing. So again, it's the command is given by the operator. I give the command and no one else gives any other command, because otherwise it will be a confusion in the cath lab. So nowadays even we do a BAV, which is with simultaneous injection. You can look at this image. We inflate the balloon and then we also do an injection. You can see that. There are advantages of doing this. Now this patient already has a prosthetic mitral valve. So this we did a TAVI for this patient who already had a prosthetic mitral valve. So you can see the mitral processes. So we have crossed the aortic valve, we are doing a balloon inflation and we inject. So when we inject, we also look at the coronaries, one. Second, we also see whether the balloon there's any indentation, whether the balloon size is okay. So we can see get multiple information from the size, coronary occlusion, everything from the injection during balloon inflation. So there are two types of valve, major, the self-expanding valve, the most common valve, which is Evolute R valve, which is again the newest generation valve, Medtronic, after the core valve. So this advantage of this Evolute R valve, the valve can be retrieved up to 80% after deployment. So once it is only 14 French, so it has got inline sheath, so the valve is loaded. Before we do a balloon angioplasty, we always look at the valve, we load the valve properly. It's important to check whether the valve is loaded properly, because sometimes, very occasionally, when the patient develops severe AR, then we need to quickly implant the valve. So that is why we have to make sure the valve is well prepared before we do a balloon aortic valvuloplasty. So we have to look at whether there is any misload after loading. It's very important. Either there is any large gap between the paddle and the pocket. So that's again to clear. If we do a fluoroscopy and we do a cine run, so if there is any asymmetrical position of the paddles within the pockets, or there is any bent or angled capsule, uneven marker bands, so anything like that, we know that it's improper loading. So the loading is usually done by the team from Medtronic, where they do the loading, and we check whether it's loaded properly by doing a cine, rotate the catheter 360 degrees, do a cine, and replay it again and make sure that it's loaded properly. So once we do that, then you achieve the coplanar image. Again, removing the parallax. Again, you can see there's a circular. I hope you can see that. We change the position, make it more caudal to make sure that circle is in a single line, which ensures that it's in the coplanar position. So that's called removing the parallax. Once we remove the parallax, so we now are the coplanar. Then we start. Once the valve is entering the LV, then we slowly start releasing the valve. So even when we move the valve from the groin up to we have to monitor, fluoroscopy, monitor the LV wire, we can move gradually, and when we move the LAO, when we cross the arch and then enter the LV. So the target implant depth is 3 to 5 millimeter. So as you can see in this picture, you can see the inflow edge, the lowest portion, inflow edge of the frame, that is node 0. And you can see the node 1 is the first marker band. So the distance between node 0 and node 1 is 6 millimeter. So our target implant depth is 3 to 5 millimeters. In a typical valve, in a tricuspid valve, is 3 to 5 millimeters. So we start deployment. We first slowly start the first 1/3 by slowly rotating, and we monitor through the fluoroscopy. and keep doing an angiogram to know whether we are in the target depth, and then deploy quickly. So second two-third is usually deployed very quickly because there may be a temporary drop in the systolic blood pressure. There is a tactile indicator where it will give us a sound that we are nearing the point of no recapture. So we stop it at the two-third. You can see that there is a marker band, there is a paddle attachment. So as we grow closer, we know that we are going near the point of no return. So we stop at that point, we check an angiogram, we check whether there is any coronary occlusion, whether the position is adequate. So once we are completely satisfied, because at this point, we can do a recapture and change the position. So one can do up to 3 times you can recapture. So you don't have to get a completely 100% satisfying position, but if you have near 3 to 5 millimeter depth, you're comfortable, then you can release, you can do the final release. Before we release, you have to release the system tension. As you can see in this picture, this valve catheter is going through the inner curvature, so you have to give some forward pressure to keep it in the outer curvature. And once you do that, then you start deploying the valve slowly, the final deployment, very gradually do the final deployment. So once you have deployed, make sure the valve is completely released. Then you can make sure the catheter tip, the nose cone, should be coaxial. Because if the nose cone is on the side of the valve, it can hit the valve and the valve can pop out. It's possible. So make sure the valve, the nose cone is at the coaxial, and then you slowly remove the valve. You moving the handle, the gray tip is pulled towards the blue, and then the valve is out. Then you check through the fluoro, make sure you check and make sure the tip is not over captured or under captured, because otherwise you'll have difficulty getting out through the sheath. So then you slowly remove it, and if you use the inline sheath, then change it to another 14. Once we remove, change it to 14 French sheath, and then we can now assess for paravalvular leak, assess for the valve gradients, assess for any complications. So this is again show how we do this routinely. So deploy the valve. This is again slow first 1/3, then this is after the second 1/3. Valve is slowly deployed, and then before we release the valve, you will check by angiogram. In this case, you can see that the valve is not fully expanded. So probably this is a case of a bicuspid valve with a high calcium. That's why you could see the inflow portion of the valve is still a lot of under expansion. And then we fully deploy, the valve is fully deployed. And this patient we did a post-dilatation. So this is after post-dilatation, and we do aortogram, we check for paravalvular leak. Sometimes we have to wait for 10 minutes and assess the paravalvular leak. Also we can assess using the TEE. Also one can use a hemodynamics, use the aortic index, and then you can get to know whether the PVL if it is significant, then one can consider doing additional post-dilatation. So after if PVL is there more than moderate, after 10 minutes, then we perform post-dilatation. And then for choosing the post-dilatation balloon, one should, safest is to use the minimum diameter. One can go up to the maximum diameter of the annulus. So this is again an under-deployed valve. The valve is not expanded. You can see the heavy calcium on one side. So this is doing a post-dilatation, and then this is the final result after post-dilatation. There is a minimal grade 1 AR, and further the AR will further reduce even during follow-up. So we accepted that. So recapturing, as I told you already, it is possible. If you have a very high implant depth of 0 to 2 millimeter, you can retrieve the valve, reposition, and again do the same process again. So now with the steps of Evolute R, now I'll briefly also go ahead with the steps of Sapien 3 valve. This is again an entirely different valve, which is a balloon-expandable valve, as I told you. So again, this has got an expandable sheath, which is a sheath is like a snake swallowing. It gives when the catheter is pushed, it expands and then it collapses when the catheter passes through. So again, the initial steps are the same. We cross the aortic valve, and once the wire is in position, this is Sapien 3 valve is advanced. The Sapien 3 valve, the valve is more distal, and you see the balloon is in the middle of the shaft. So from the catheter, we will have to push the balloon into the valve after in the body. So the reason is they want to reduce the profile of the valve. So they kept both the balloon and the valve separately. So you will have to introduce the balloon into the valve inside the body. So that's what we are doing now. You could see the second image. Can you click on that, please? So here you could see that now we are positioning the balloon You can look at the middle image. So the balloon is moving now. It's coming into the valve slowly. So now in the third image, you can see the balloon has come from distal, it has come into the valve now. So we make sure the balloon is well kept inside the stent of the valve. Next slide. Once that is done, then it's advanced. The SAPIEN 3 valve is advanced. Next. So the valve is in position now. Once we keep it in position, then we keep the pigtail. There's a central marker in the S3 valve. So the central mark, can you see a dark marker there? That S3 valve, yes. That marker is placed exactly at the annulus. So we can even keep it just below the annulus. We want to achieve a position of 60-40, which means 40 in the ventricular side and 60 in the aortic side. And we can even do a 70-30. So 70-30, ideal position would be 70-30. So we want to keep 70 in the aortic position and 30 in the LV position. Okay, next slide. So once we show the deployment. So this is a deployment. So you have to use rapid pacing. You see, first we do an injection. We make sure with the rapid pacing, injection, and check whether the position is adequate. Pull the pigtail out. Once the pigtail is out, inflate slowly. We inflate it, and then once we inflate, then we completely deflate. We have to maintain the pacing up to complete deflation. Otherwise, the valve can pop out. So we have to completely deflate and then stop pacing. That's important. And once pacing stops, then we can remove the catheter, remove the balloon out of the valve. Then you can assess the hemodynamics, check angiogram, and again you show there is absolutely no paravalvular leak in this case. So this is again one of most of the time with the SAPIEN 3 valve, we don't have much of a paravalvular leak. So the another important step now is to close the groin. Again, I am not going to go in detail. What we use is we generally use the proglides, and we close. Once we remove, we always have an alternative access from the other groin. We have a catheter because in case of a problem, we need to have an injection. So we keep the catheter and we close the proglide. Once we remove the big sheath, we pull the proglides, and the proglide again has a learning curve. But now we are very comfortable. We have done all our cases. We have not done cut down. Only one case in Madurai we had to do a cut down, and otherwise all our cases went with proglides. We're very comfortable with proglides. But of course we had some issues. We had one of the cases we had narrowing, too much of narrowing. We had to put a stent, and one patient we had to do just a plain balloon dilatation. So these are sometimes a problem, and sometimes there is a bleeding, and if you reverse the heparin, it settles down. So this patient, we close the proglide, and you can see there is absolutely not much of narrowing. It's very well, proglides have worked very well, and so we got a good result. So finally, to conclude, how do you define device success? How do you define device success? So as assessed by transesophageal echo, aortogram, and also the hemodynamics with AR index immediately after valve deployment, there should be no significant AR, no significant gradient, and successful valve delivery, successful vascular access, and correct position of the device in proper anatomical position, and with only one valve implantation in the proper implantation. This has been defined as a device success. So I think I went step by step. Now I think we will also hear from each one of the experienced operators here on how they will do it differently, and you can also ask questions on in any of these steps what I told now. Thank you.
I think this was a extremely comprehensive presentation of how do you do step by step, and the time you took was about half an hour or so, and I think the same time is spent on doing it also, generally about 30 to 45 minutes, because many people ask this question, how much time does it take to do the procedure? So from the puncture to finish, generally it is about half an hour, so that's how quick the procedure is actually. And I mean, typically, as you said, that you do, what percentage of your patients is done under local and what is general anesthesia?
Initially we were doing 50-50, now we are moving more towards local.
Okay. So that's, for me also it is almost similar, because it is all dependent upon what is the plan of the procedure, what complexity the patient has, whether we are going to do an open access or a closed access, and I'll discuss also in the next presentation, how do we choose what kind of access we have. So basically, doing a GA versus local or open versus percutaneous, is not dependent upon your experience, it is dependent upon the anatomy and the complexity of the procedure. So that's how we take these decisions. So, my colleague, you to add a few things?
Maybe you can comment on the aortic valvuloplasty.
Yeah, actually, nice presentations. Actually, one of the important things in deployment is the coordination between the first operator and the second operator.
Dr. Muthu is second. He's a part of our TAVR team, and he has a huge experience along with us. So he does most of the balloon inflations when we have the balloon, so he can share his experience.
So particularly in Sapiens valve, the role of the first operator command is very important, because if we pace or not pace at the time of the aortic valve implantation, is most likely the valve will embolize, and only one voice should be in the cath lab, and the inflation of the valve should be done in a steady process, and slowly but steadily, and then we have to wait for 3 or 4 seconds at the end of full inflation. So the valve nicely anchors to the calcium and other tissues around, and then slowly deflate it. So this process should be done, and the cath lab should be silent at the moment, hearing the command from the first operator. If the anesthetist paces the patient, stop pacing the patient before the valve is deployed, then the valve embolizes. So it's a very crucial step during the valve implantation.
How will you select core valve or sapien valve? How will you select these two valves?
Okay. So we look at basically the core valve evolutor as a self-expanding valve, and now we have almost stopped using core valve. Because core valve is not retrievable once we deploy it, and you can't do anything about it. So the evolutor is an advanced form of a core valve. So this is much more, 80%, up to 80% we can retrieve it. So it's a self-expanding valve, which doesn't require very often it doesn't require rapid pacing. You can do a slow pacing during deployment. So whereas the Sapien 3 is a balloon-expandable valve, which always requires rapid pacing. So we look mainly two things. One, if the patient has severe LV dysfunction, sometimes they don't tolerate rapid pacing. We have seen some patients having a brief arrest if you have a rapid pacing when they have EF is very low, like 25%. So such cases you want to avoid rapid pacing, then self-expanding valves like evolutor would be the best we can try without a rapid pacing. The other thing where we consider when the patient has extreme severe calcification, a bicuspid valve. Generally, when you have bicuspid valve with extreme calcifications, sometimes extra eccentric calcification, such patients we always tend to use a self-expanding valve. And LVOT calcium, if there is LVOT calcium, we would again use a self-expanding valve. We don't want to use a balloon-expandable valve when there is LVOT calcium. So these are the broad indications where we decide, and 80% of the time we can choose any of these two valves. Only in 20% we have to be very fixed on a particular valve. For another thing is when you have a hugely dilated ascending aorta, sometimes a self-expanding valve may not have a big anchor, so one would consider using a balloon-expandable valve. So, Dr. Ravinder, can you share your views also?
I think that was a master class on step-by-step approach to transcatheter valve procedures. Congratulations. But I totally agree with you. It is the coordination of two operators who are doing these procedures together, like a balloon dilatation. So we have now moved on to conscious sedation, but as clearly pointed out, it is the patient profile and complexity which is going to decide conscious sedation versus general anesthesia. It is not a big deal that we are doing a case under conscious sedation. If we think ahead of time that we might end up evaluating more, like doing a TE, if we think that patient valve implantation might go complex, it is better to do under GA and TE in down the esophagus. But I think that was an excellent presentation.
Yeah, so basically, for example, as you said, bicuspid aortic valve. Typically, most of us would like to have a transesophageal echo monitoring throughout the procedure. So it's general anesthesia. So that's how, but the best thing, which I must tell you all, is that we got initiated in India at this stage where this technology has already evolved to a stage where it is very, very safe. Somebody asked this question as to what is the safety of this procedure. In most of our labs, I think it is above 99.9% successful procedure. And then subsequently, there are many very sick patients we have taken, whether it's chest infection or there are other comorbid conditions, which actually lead to subsequent morbidity or mortality. But because of the valve, I have not seen any, mortality happening just with the implantation process or soon after that.
We use an app called a TAVR Mortality Risk app developed by American College of Cardiology. So that app, we use it for risk assessment and gives exactly says 5% mortality, whatever, depending on the risk. So we use that and we have some authentically say this is the risk for that particular patient. So in our practice so far we have not used filters, but yes, of course, for cerebral protection, there are filters which can be useful. They put it through radial approach and to reduce the incidence of cerebral embolization, stroke. But again, the recent studies have not been shown any big promise of using these filters. And I practically have not used filters in any of our cases. And Dr. Ravindra, you used a filter?
So, I've used this Claret device as part of Sentinel trial. As you clearly pointed out, you go from the right radial, deploy a filter in the brachiocephalic trunk, and another filter goes in the left common carotid artery. But as sir has clearly pointed out, there is no clinical benefit. There are MRI evidences that yes, the embolic shower is less, but that hasn't transformed into real clinical benefit as of now. But FDA has approved Sentinel device for cerebral protection just on that basis that the FDA inspectors thought that if they will have a TAVI on themselves, they would like to have a cerebral protection device in place. So it is FDA approved now, but no clinical.
Since some of the environments are doing TAVR, there is a lot of complications. We have got the next topic on complications. I think that can be covered in detail by Dr. Praveen.
Sir, I think what Shivasan says is right, but we haven't had any cerebral complications in our experience with our groups. Yourself, sir?
Yeah, so in our experience, and also I heard, because we keep communicating with each other, in about 200 patients which have been done, more than that, in India, none have had any cerebral major stroke. Minor, strokes could have happened, but major stroke or any, disabling stroke has not happened in any of these patients. That's why we are saying that we are lucky that we started at this time. The device is 14 French, etc.
I was in Japan. I was coming across a cardiologist from Taiwan who had a procedure. Showed he had, after the TAVR, the patient didn't wake up from anesthesia. For about 4 hours, 5 hours, he didn't wake up. So then they decided to do an MRI. They found MC occlusion. So it was stroke. Then they called the interventional radiologist. They gave a direct they used a stent and removed the thrombus. And the patient was 12 hours later completely improved, no paralysis, nothing. So patient went home walking. So we have to be careful, vigilant, watch, and then if there is anything, we have a team. So we have an interventional radiologist who can do this job and bail this out. Yes, as far as stroke, looking at this stroke, definitely LA would be better than GA. If you want to, identify stroke very early. Yes, definitely.
We did one transcranial study during early stage of core valve, and very worrying thing was the first wire goes in, you get bing, 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 and then the catheter goes in, normal catheter, it goes bing, 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 and it's very difficult. So unconsciously we are sending a lot of microemboli. By none of them, the first 50 patients 9 years ago. Then 10 years mortality was 0. There are two major complications like pericardial tamponade due to pacing wire and femoral complication, but they all survived for 30 days. And one of the complications of core valve initially was the pacemaker incidence was about 27% in need of the pacemaker. But it was 9 years ago. Now the valve is getting smaller, sleeker, experience getting wider. The incidence complication is very, very less now.
So balloon-expandable valves, again, is one of the important types of valve to have in our lab. We are very fortunate to be one of the 5 centers in India to have the Edwards SAPIEN 3 valve. So unlike the Medtronic, Edwards was launched only in 5 centers, 2 in Delhi and 2 in Mumbai and ours in Chennai. So we as a team, we had some training in Cedars-Sinai Hospital in Los Angeles. And then we started our Edwards program in November last year. And so since then, we have now just started November. So 2 cases of balloon-expandable valves using SAPIEN 3 was done. So SAPIEN 3 is again excellent valve which has got, if you look at, it has got an outer sealing skirt which prevents paravalvular leak. And the frame design is like that. The upper cells are large, just to prevent have a good coronary flow, and the lower cells are small to have better radial strength. So this is again 14 French delivery sheath. The valve is again inserted usually by the femoral approach if it is good, and it is a balloon expandable, as you can see, during rapid pacing. It is implanted using rapid ventricular pacing. So the incidence of paravalve leak is extremely low with this device, and even the pacemaker rates are much lower. So having this device in our lab is again very useful because we can use it selectively as per the needs of that individual patient. So again, the partner trial, which was done with this partner 1 initial trial with Sapien and Sapien XT valves, and now we have the very long follow-up of 5 years, which has shown a significant mortality benefit with the Sapien valve, Sapien 3 valve. And also the partner 2 trial, as we just discussed, has moved the indication to intermediate risk group. And this is partly partner 2A and 2B. It was a trial which started with the XT valve, Sapien XT valve, and also they included the Sapien 3 valve, and which has again shown non-inferiority to surgical aortic valve replacement in intermediate risk patients. So we had 2 cases. So I would present one of the interesting cases which we did recently using Sapien 3 valve. Again, as I told you, some of the indications where Sapien 3 valve will be really useful is patients with this is a condition. This is a situation where we had to use Sapien 3 valve. So this is a 70-year-old lady with rheumatic heart disease. Again, this is one of the first cases where we used in India, where we used TAVR for rheumatic aortic stenosis. This patient had a history of closed mitral valvotomy in 1978. She had subsequently had a mitral valve replacement with bioprosthetic valve and DVGA's tricuspid annuloplasty in 2003. And she had probable infective endocarditis, which was treated in 2005. She's also a known diabetic and hypertensive. She had history of atrial fibrillation. She also had right internal carotid artery stenosis, the 90% stenosis. She was diagnosed to have normal pressure hydrocephalus. She had severe bronchial asthma, and she was diagnosed to have severe aortic stenosis with recurrent hospital admissions. She had class 4 symptoms. Added to all that, she had a syncope and she had a fall, and she had a severe epistaxis leading to cardiac arrest, and she had to be intubated because of epistaxis. Just to protect the airway, she had to be intubated. She was in the ICU a long period of time. She also developed fever, infection, possibly a fungal infection. So with all that situation, the surgeons completely refused surgery. In fact, 2 years ago, she was taken up for surgical AVR and brought her back and saying that the risk is too high to be considered for surgical aortic valve replacement. So echocardiogram showed severe aortic stenosis, no calcium, rheumatic etiology. The aortic valve area was 0.5, mean gradient was 45, and the mitral prosthesis was functioning well. So she had an extreme high risk STS score with a mortality of 14.2%, and she was rejected by CT surgeons. So with such high risk, in fact, our surgeons felt that a patient even taken for TAVR may not make it, and in fact discourage the patient to have any sort of procedure. So, but we had no other option. We had to wait, and the ENT surgeons did a lot of packing. Epistaxis improved. We extubated, waited for ID clearance, and they cleared that there's no fungal infection. Cleared for infective endocarditis, no evidence of infection. So then we explained the high risk, and finally we decided to do a CT and take her for TAVR. So when the CT showed annulus area of 318 square millimeters. Again, for doing a balloon-expandable valve, we look at the we look at the area and calculate the annular diameter. So in this patient, the coronary height again was an issue. The left side was borderline very low, it was only 10 millimeters. The right coronary was 13.9 millimeters. She had tricuspid aortic valve, but very, very low calcium, almost no calcium. So this is again a big challenge. Coronary arteries were normal, the femoral arteries were adequately sized. So in such situation, when you have a near normal and to no minimal calcium, the risk of valve pop-out is high when there is no calcium. So the major challenges, as I said, was the very minimal calcium. Also, the presence of previous mitral processes again can sometimes cause the valve to pop out because of the pressure. The valve, the mitral process itself can cause valve pop out and the valve can get embolized. So, and also if the valve is implanted little low into the LVOT, there is a possibility of mitral paravalvular leak. It may catch up on the mitral prosthesis. So that is also a concern. We can have a low implantation. The another challenge was she also has a low left coronary artery, which is only 10 millimeters. So we have a risk of coronary occlusion. So we can't have a high implantation, we can't have a low implantation. It should be precise implantation. So high can cause occlusion coronary and the low implantation can cause a mitral prosthetic problem. So in such situation with low calcium, self-expanding valve, we thought it would have a higher chance of valve embolization. So we thought balloon-expandable valve, if we oversize it slightly, we can probably hold it there. So that's what was, we expanded with the balloon with a slightly oversized valve. So we went by femoral approach, ultrasound guided puncture, and we used 2 proglides. So Edwards 14 French sheath. We used a balloon tube pacemaker in the right ventricle. So we used a balloon aortic valvuloplasty, which was again done. During that we give an injection. This is again important to do an injection just to make sure the coronaries are not occluded during the balloon injection, balloon inflation. So that also reassures us. It won't, even if after the valve implantation, the chances of coronary occlusion is going to be low. So that was a little bit reassuring. So then we positioned the valve, and this is the valve deployment. So valve was in precise position. We got it right. So fortunately, it opened out very well. There's no coronary occlusion. There's no paravalvular leak. The femorals were all right. So this was again a good demonstration where this is a suitable patient with low calcium, where really balloon-expandable valve made a difference, and she did very well. And she came for a follow-up last week. We couldn't believe she was completely much better. She was walking, doing her activities. So that kind of a recovery was very surprising to us, looking at the situation how she was earlier. So really TAVR made a huge difference to her life. So similar to this, we had again to summarize, this is the first time rheumatic aortic stenosis was treated with along with the functional mitral processes was treated with the SAPIEN 3 valve, and slightly oversizing the valve helped to achieve a very stable position, and meticulous CT assessment, sizing and positioning the valve at correct place are very crucial to get the best outcome in this very high risk case. So we had one more case with the balloon expandable valve. I think for some short of time, I think I will just show one case. So another important valve which is going to come to us shortly is Indian valve, which is again a balloon expandable valve from Merrill Life Sciences called the MY valve. We've just completed the initial studies and also completed animal studies, and it's soon going to start the first in man clinical studies, and we are one of the centers which will be involved in doing the first in man study. So this is again a similar design with upper big cells, and the lower cells are smaller to increase the radial strength. And this valve will come in 4 sizes, and with a delivery system where this valve will have both the balloon inside the valve pre-mounted, and this is the bench testing which is shown to have good tensile strength, and also gone through several durability tests, and it has been tested in animals in swine models, and it has shown to have good hemodynamics. So the valve has been tested in orthotopic position in the swines, and now we are ready to undergo human studies. So the MyValve 1 Indian first in man study will be planning 30 patients. There will be a minimum of 5 investigatory sites in India, and so the follow-up schedule will be 13 days, 6 months, 1 year, and annually up to 5 years. So we will be, these patients have rigid inclusion-exclusion criteria. The inclusion criteria will be the STS score more than 8 and a tricuspid valve. So I would encourage you to consider, to enroll these patients. If you have such patients, we can always enroll these patients as free of cost for this trial. This trial will probably give some data on the Indian valves. To conclude, balloon expandable TAVR systems is an excellent technology, and having a choice of both self-expanding and balloon expandable valve offers advantages, and we can choose the best suited valve for that particular patient. And Sapien 3, which is the most advanced valve from Edwards, is presently available. And also now my valve will soon start the first in-man study to establish safety and effectiveness in this high-risk surgical population. Thank you.
Congratulations, Dr. Sengottuvelu, for this excellent talk. Two personal questions. One is, the case you described had previous infected endocarditis. Suppose while evaluating you find a healed vegetation, would you proceed on with TAVR or a small heal? The big one obvious, but it's a, say, 1 millimeter size healed vegetation.
If there is an active ongoing infection, then at least we have to wait for 6 to 8 weeks and make sure it's completely cured, give adequate antibiotics made and then do the TAVR. But in this case, actually there was some suggestion of infective endocarditis in 2005 and presently there was no evidence of infective endocarditis. So we had some doubt on fungal infection, but again it was our infection disease, they ruled it out saying that it is a contaminant. So, that is, and she was afebrile and counts were all right. So we were quite comfortable and we were sure that she didn't have any ongoing active infection. So again, that is it's a relative contraindication. We would not consider doing such a high risk procedure when there is a suggestion of infection.
No, I'm talking about healed vegetation.
Healed vegetation.
Whether it will embolize.
Yeah, healed vegetation should not be a contraindication to do the procedure. And we have not had much experience on that, but it should not a contraindication to do TAVR.
My second thing is, suppose the patient had mild aortic regurgitation, would you be worried about TAVR always causes a little bit of AR, so would it worsen the aortic regurgitation?
Actually, as was discussed previously, it is clearly shown that patients who have no AR do much better than minimal AR, minimal PVL, and patients with minimal PVL do better than moderate PVL. So currently, if there is anything minimal PVL, we can accept it. But whereas anything more than minimal, if it is a moderate PVL, one should consider doing either a plug or post-dilatation or doing a valve and valve with another valve. One should address if there is more than mild PVL. But one of the advantages of using Sapien 3 is there is very minimal or zero PVL. I have seen most of the cases what I have seen with Sapien 3, we have not seen any PVL. And even with Evolute R, we have seen PVLs more commonly in bicuspid aortic valves, but not in very minimal PVL. And also over time, the valve keeps expanding and the PVL decreases.
Dr. Sengottuvelu, one small question, not related to your case. When you're doing these cases, if they're very calcified aorta, especially arch, have you faced any problem getting it across without any embolization?
Yeah, it's again a very, very valid question. Some of these arches are more challenging, particularly when it is more tortuous and more calcified. So the only thing is the risk of complications are, of course, one thing one should keep that in mind. But when we have difficulty in tracking, we always try to use support wires or very stiff wires like Lundquist wire. Lundquist wire is the stiffest wire. So one of these wires sometimes help to track when you have such difficult situations.
Very.
Correct.
So many common asthma, diabetes, hypertension, age, whatnot. Apart from previous infected endocarditis infection.
Unfortunately, sir, these are the patients now surgeons give it to us. They don't want to give any lower risk or medium risk patients as well. So we will have to face these kind of, over time, the surgeons slowly will know that the TAVR gives good results. So we will get more less riskier cases. That is why, the risks overall is high. But fortunately, we came out well in this case. But these are all, as you said, very high risk cases.
What is the risk of, percentage of risk you explain to the patient?
So, as I told you, fortunately we have the TAVR app. I told you there is an app which we use it to calculate, and based on that has particularly COPD and renal issues and all that. For her, we gave a risk of mortality of 10%. But again, surgical mortality even is very high. So they accepted it.
Sir, one more question, sir. Thank you, sir. Very excellent information you are providing today. My question is, as such calcification is holding the valve, but either you use a self-expanding or a balloon-expandable valve, after the deployment, still once it is getting scaffolded with the aortic valve, and that stays on. So other than calcification, exactly what is holding the valve? Say for example, even if the aortic rim is deficient, when you choose ASD device, sometimes if it is really straddling across the aortic valve, that is really staying on. Something like that. What is the role of the aortic, the fibrous skeleton exactly here?
So basically the annulus, the annulus is the one which is tight fitting the valve which holds. So calcium will hold it better. So when you have no calcium, that is why we try to oversize so that the valve stays. So in spite of oversizing, in this case we really had a risk of valve embolization, because from the mitral processes as well. So we were very cautious, waiting whether valve, we were prepared to handle in case the valve embolizes. But fortunately we went well. So, but again, the annulus, and that is the main thing. That's why if you oversize a little bit, that itself will hold the valve.
I think if that's all, we'll congratulate Dr. Sengottuvelu for a wonderful talk. Move on to the next session.
So our experience in bicuspid aortic valve. Next slide. So as we know, the bicuspid aortic valve classification is Siever's classification, where there is no raphe at all is type 0, which is only 7%. Type 1 has 1 raphe. Depending upon where it is, it can be on the left to right or non-coronary to, it can depending on that. The most common type is that 1 raphe, and again type 2 is 2 raphe. Again, it is very infrequent. Again, this is actually proposed by the surgeons. Next slide. So bicuspid aortic valve was relatively considered as a relative contraindication, and in fact it's an off-label indication. And it has been not even indicated in the IFU of approved devices. So because it is not included in the trials. So now more and more increasing data, it's supporting its use. Next slide. So the challenge is, you can see this, if it is a tricuspid aortic valve, the prosthetic valve will open uniformly. Whereas in a bicuspid valve, the orifice is almost like an elliptical orifice. And hence when we use a circular valve, in the sides, it may not have a complete closure and can result in paravalvular leak. Next slide. So, the main problem with bicuspid aortic valve is high chances of paravalvular leak. And bicuspid aortic valve is associated with heavy calcification compared to tricuspid valve. Also, aortic root disease. See, I was recently, one of our friend from Singapore had a patient with bicuspid valve, and when they were taking the valve in, they had extensive aortic dissection. And then when they deployed the valve, it all went well, and when they removed the valve, they went to surgery. Even the surgeons felt the sutures were not able to take it. So these patients have aortic disease. So one has to keep in mind that when you have bicuspid anatomy, anticipate that they will have aortic disease, and be very careful in manipulating when across the aorta. So greater chances of dissection, and these patients have very large annulus and heavy calcium. Next slide. Next slide. So appropriate case selection is very important, and these patients should always require pre-dilatation, because we need to extensively pre-dilate, and also will require post-dilatation, because very often they result in paravalvular leak. Next slide. So again, sizing has been slightly modified over the years. Now instead of sizing at the annulus, for bicuspid aortic valves we size 5 mm above and 8 mm above the annulus. That is because to get the most constriction is slightly above the annulus. So to get a better sealing, the sizing is done at the 5 mm, 8 mm levels. Again, 3 points we make the measurements at the annulus, at 5 mm, at 8 mm, and of these we choose the valve at least where it matches two areas, either at 5 mm, 8 and at the annulus level. Next slide. So our experience, we have done 6 cases, 4 males and 2 females. The mean age was 76, and 5 had high STS score. Next slide. So I will quickly go through the cases. Next slide. This is a 54-year-old lady, very young, one of the young ladies who had a bicuspid aortic valve, very high risk. Next slide. Go next slide. So I will just quickly rush through. So this patient, the next slide, had a normal coronary. Next slide. So she had a bicuspid aortic valve with heavy calcium. Next slide. So we used a evolute R valve. We pre-dilated. Next slide. So after pre-dilatation, next slide. We are taking the valve in with the evolute R valve. Next slide. Slowly deploying. The valve, you could see that the valve is deployed now. Next slide. So the next slide. So we had to post-dilate, the valve is not fully open, there is some under-expansion. So we had to post-dilate. Next slide. So this is the final result. We didn't have, after post-dilatation, the paravalvular leak was minimal. Next slide. So I will just rush through these cases and I will give you a message why, what is important in bicuspid valve. This patient the procedure went very well, we discharged, but please note that this patient had to go both pre-dilatation and post-dilatation, and evolute R valve was used. Next slide. So again, this is a second case, 90-year-old man, severe aortic stenosis, very high STS score of more than 20%. Next slide. Post CABG, ejection fraction was 30%, one of the very high risk cases where we have done. Next slide. So this patient, you can see the CT on your right, clearly shows a bicuspid aortic valve, eccentric calcium, more calcium on the left side, non-coronary cusp. Next slide. So we did this procedure again. Next slide, through femoral approach. This is after evolute R deployment. There is some problem with the femoral. You can see the femoral flow is not good. So we had to do a balloon dilatation. Next slide. And then everything went well. Patient was discharged on day 4. Again, this patient, however, needed pre-dilatation, but we didn't have to post-dilate. But again, it was a challenging patient. Next slide. The case 3 is an 80-year-old, is again one of the anatomically challenging cases. 80-year-old man with interstitial lung disease, and he had a STS score of 6. Next slide. Next slide. So again, you could see in the previous slide, you can see the bicuspid aortic valve and the CT on your right. There is some amount of calcium, and the problem here is on the left side, if you see the lower panel, that is the cut section across the left ventricular outflow tract. Calcium is extending into the LVOT. So that is an important point to consider. So there is a high risk of LVOT rupture if you do aggressive pre-dilatation. So in this case, we used a self-expanding valve. Next slide. So even the aorta was very tortuous. You can see the calcium, heavy calcium. Next slide. So this patient, in view of the heavy calcium, we had to pre-dilate. But the problem is, if we pre-dilate, we also carry the risk of LVOT rupture because of the LVOT calcium. So we have to balance. We can't do aggressive pre-dilatation, but we have to do pre-dilatation because it's a bicuspid valve and there is heavy calcium. Next slide. So we did a pre-dilatation and we deployed the valve. You could see the valve. You see the inflow portion of the valve. It's very narrow. I'm not having a pointer. Can you point? Yes, you can point out. That is the inflow portion of the valve, which is not open because of the heavy calcium. So we had to do a post-dilatation, and we are doing a post. You can see on the middle image, we are doing a post-dilatation, and after doing an aggressive post-dilatation, we are now seeing it's slightly better. And we assess the paravalvular leak. We do an aortogram. We assess the paravalvular leak based on 3 parameters. 1, hemodynamics. You look at the aortic diastolic pressure, aortic AR index. Number 2, do an aortogram. By aortogram, we can see. Number 3, we look at the transesophageal echo to look for a paravalvular leak. So based on 3 parameters, if 2 are acceptable, we can accept it. Next slide. So this is again, we use another little higher size balloon, post-dilatation, and we took a risk of aggressively dilating in spite of LVOT calcium because he has significant aortic leak. So we had to again balance, step up the balloon, and then we did post-dilate cautiously. Fortunately, the valve opened. There is very minimal paravalvular leak, grade 1, and we accepted that. Next slide. So again, in this case, we had to pre-dilate cautiously and also post-dilate aggressively in spite of LVOT calcium. But this is the problem with bicuspid aortic valve. You have to pre-dilate. In spite of pre-dilatation, we have problems. Again, post-dilatation, it doesn't open well. Next slide. So this is case 4. This is next slide. So this patient again is a young lady who was referred from another hospital. She was on a ventilator with class 4 symptoms, with severe aortic stenosis, severe COPD. So on ventilator, she was shifted. We found that she has, you can see on the right panel, again it's a bicuspid aortic valve. Next slide. So next slide. So we had to go through the femoral. She had already an AV fistula. Next slide. So we crossed the valve. We used again a pre-dilatation. After pre-dilatation, we used a evolute R valve. Next slide. Again in this next slide. So here we could see that there is a moment of under expansion. So we did a mild post-dilatation. Next slide. So this patient after post-dilatation had minimal PVL, and now she is doing well, and I saw her recently also. So she had some long hospital stay, but after about now nearly a 1 year follow-up, she now is doing extremely well on clinical follow-up. Next slide. So case 5 is an 87-year-old man, severe calcific aortic stenosis, again a bicuspid aortic valve. Next slide. Next slide. So you could see the CT can clearly show the bicuspid valve with again eccentric calcium. This is again a challenge. We have calcium towards one side. Next, again the calcium is in the LVOT. You can see the burden of calcium, huge amount of calcium in eccentric position. Next slide. So when the calcium is again extending to LVOT, these are, you can see even in the fluoroscopy, you could see the calcium, more extensive calcium. So we are predilating the calcium. Again, predilatation, next slide. So predilatation, very important. And then similar appearance of the valve. You see the valve in the inflow portion is not expanded at all. Severe narrowing. So here we had to, in fact we were worried when we pull out the nose cone, the valve will pop out. So we had to do a buddy wire and put one more wire into the LV, pass a balloon, dilate, and then remove the nose cone. So we had to do that because it's severe narrowing at the nose cone. Again, post-dilatation, next slide. Post-dilatation, next. Then the valve is slightly better now. Next slide. So this is the final result after post-dilatation, and we have very minimal paravalvular leak. Next slide. So this is the next slide. You can keep moving. So this is the last case of our bicuspid valve. This again this is one of the big nightmares actually. 69-year-old man who has severe COPD, severe calcific aortic stenosis, and he had a very high STS score, 9.32 mortality, and he had recurrent hospital admissions. He was oxygen dependent, and the surgeons refused surgery. Next slide. So this patient had a type 2 bicuspid valve. The problem was huge chunk of calcium in the left coronary cusp. It is threatening to occlude the left coronary. Next slide. So you could see the can you run that? If you could see, the calcium is eccentric one side. So our worry was two things. One, whether the calcium will expand, the valve will be able to expand well. The second issue was whether the bulk of calcium will move into the left coronary and occlude the left coronary. So there are two big challenges. So we were worried about that. So next slide. So what we thought was we'll do a pre-dilatation and check whether the calcium moves into the left main. Go back. Yeah, you could see the calcium now. It's a bicuspid valve on the left. You can see the CTR. There's a huge eccentric calcium. It's not uniform. If the calcium is uniform, then it is better. But if you have one side calcium, it's again a challenge in opening the valve will not open uniformly. Next slide. So this is the implanter's view, and huge. You can see the calcium amount of calcium. So as I told you, we do different cuts at 5 millimeter and 8 millimeter planes to assess the size at different levels. Next slide. So the valve is chosen depending upon the sizes at multiple levels as opposed to a tricuspid valve. Next slide. So this was done. Next slide. So this is done again using a evolutar valve. Next slide. So you can see the calcium. So we did a pre-dilatation carefully, and during the pre-dilatation we did a TE. The calcium was not moving at all. The left coronary was quite patent. We did an injection during the dilatation. Next slide. So we were happy that the calcium was very stable. Then we could see we're taking the evolutar valve. We position the valve. As again in this case, we can point out there is the inflow of the valve is narrow. It is on the left side. Now the inflow of the valve is very narrow. It is not open. The same problem again, where because of the calcium, the valve is not fully open. Next slide. So we had to do a aggressive post-dilatation. See, we are up. Again, we were very careful because of the heavy calcium. We first stepped up the balloon slowly. We went up with a smaller size balloon. We waited for some time whether the valve expands. Then we increased the balloon slowly. The same balloon we repeated again, one more post-dilatation, because we wanted to give more and more time and see whether the valve expands. We don't want to aggressively open the valve, which can result in complication. So slowly we were able to achieve, and the final result, this is the final result. We did do the aortogram after the final post-dilatation. We did aortogram, which shows you can see there is only grade 1 paravalvular leak, and even that paravalvular leak improved. Grade 1 plus paravalvular leak, which also improved before discharge. Next slide. So this is the final result. So next slide. So in bicuspid, next slide, patient did extremely well. Next slide, forward, go forward, yeah. So if you look at the literature, this is one of the literature where it shows the mortality was 8.6% in 30 days and the parallel leak was 30%. Next slide. This is a recent data from American College of Cardiology, which clearly compares, it just presented 2 weeks ago, last month in ACC, where it compares bicuspid and tricuspid. The risks are very high. Aortic root injury, higher in bicuspid valve. Second valve implantation, significantly higher in bicuspid valve. Parallel leak, significantly higher in bicuspid valve. New pacemaker, no difference. Device success, much lower in bicuspid valve compared to tricuspid valve. So clearly the ACC registry data shows that the risks are much higher in bicuspid valve. Next slide. However, even though the risks are higher, by 1 year, all-cause mortality rates were similar between bicuspid and tricuspid valves. So which means that at 1 year, the outcome is the same. So though the procedural success is much lower and the complications rates are higher with bicuspid valves, the long-term follow-up, they do well. Next slide. So our experience, small experience with 6 bicuspid valves, and next slide. So one of the interesting things about our experiences, out of our TAVR cases, we have seen 43% of our cases are bicuspid valves. Unlike the Western data, which shows that only 15% of the TAVR cases are bicuspid valves, 85% are tricuspid, our own experience has shown that 43% is bicuspid valves. Also, the data from Medtronic also says the Indian experience also has about 40% bicuspid valves. We don't know the reason. We don't know by Indians whether we have more bicuspid valves or we don't know whether we are seeing more younger patients. They come early with bicuspid aortic valve stenosis, which we don't know. But we are definitely facing more bicuspid valves which are have to be pre-dilated. Evolute R is a better valve because we can be repositioned. And next slide. So all 6 had significant improvement in functional class. Echo showed very trivial to grade 1 paravalvular leak at 3 months, and all of them are doing clinically well. Next slide. So summarize, our results of bicuspid valve TAVR are consistent with registry data in ACC registry data, and in these cases, when we do TAVR, you have to give attention to proper case selection, adequate pre-dilatation, proper preparation and attention to proper sizing with 3 levels of sizing in the CT, and very adequate imaging, particularly TEE, to assess what happens during pre-dilatation, and finally to optimize, we have to do adequate post-dilatation, again carefully to avoid into any complications, and manage paravalvular leak adequately. With these, we can get a good result in patients with bicuspid aortic valve. Next slide. Thank you for your patient listening.
Thank you, Dr. Sengottuvelu. I think I should congratulate you on trying out to do these cases, because basically, as you said, for most of these trials, the bicuspid aortic valves were excluded, number 1. Number 2, they are technically more difficult and difficult to size, and paravalvular leaks being more common, risk of complications being higher. And with all this, I think you've done an excellent job. I would like to congratulate you specifically and your entire team for having put together these beautiful cases. Now, just a small listing. Is it absolutely contraindicated to use balloon-expandable stents, or basically because both are available, you would use preferably self-expanding stents?
Actually, if you look at the US data, the registry data, they've used equally both the balloon-expandable and self-expanding valves. In fact, in the ACC data, the majority were balloon-expandable valves. But you can, if it is a plain bicuspid valve without much calcium, one can consider using a slightly oversized balloon-expandable valve. But what we have seen is most of, at least in our experience, we have seen that most of these bicuspid valves are heavily calcified, and when you have to eccentric calcium, the balloon-expandable valves can tilt. In fact, one of the patients were initially evaluated for a balloon-expandable valve, and for the first time we sent when the balloon-expandable valve Sapien 3 was launched in India, the first procedure case was a bicuspid aortic valve. We sent it to the proctor, and the proctor said no for a bicuspid aortic valve. It is one of the no's, because he was feeling that the valve can tilt. So we have not done a single case with the balloon expandable valve. All our bicuspids were with self-expanding valve, and we were happy with the results. So in my opinion, bicuspid valve, the first option should be a self-expanding valve. But although the ACC registry data, they have used a lot of bicuspid, the balloon expandable valves for bicuspids.
Yeah, as you said, probably the amount of calcium might decide which would be a better valve to use, number one. Number two, what about the paravalvular leaks? Are they stable over a period of time to very mild, or do they become worse over a period of
Excellent
time?
question. So the paravalvular leak, again, depends on the type of the valve. So if you have a self-expanding valve, the self-expanding valve continues to expand slowly over a period of time. So when you see at 1 month, 3 months follow-up, I think next session we will have some interesting session with we have followed up with patients who see that the paravalvular leak, even from grade 1, it becomes 0 or even no minimal paravalvular leak. So that will happen in a self-expanding valve, but in a balloon expandable valve, it won't expand. So whatever paravalvular leak has, it will remain. So that is one thing, but when you have to accept paravalvular leak if it is grade 1, but if it is more than grade 2, we should not accept, because the long-term results are not good if the paravalvular leak is more than grade 1, it is grade 2 or more.
Do any of these cases require a repeat balloon dilatation later on follow-up for paravalvular leaks, or most of it is done on table and,
it's done.
Taken care of on table most of the time?
As I told, the paravalvular leak, if it is more than grade 1 plus or more than grade 2, one should take care of it at that time. It is not going to improve. If it is grade 1 or plus, grade 1 plus, we can leave it. So if it is more than grade 2, at that time we have to consider doing further post-dilatation. If the post-dilatation doesn't help, do a valve and valve. We can put one more valve. So another valve will increase the radial strength of the valve, and it will further expand and reduce a paravalvular leak. That is the whole idea of doing a valve and valve. If that doesn't work, there are reports of putting plugs for the paravalvular leak. So these are the options. So if it is more than grade 2, you should treat it at that time.
Okay, Doctor. Thank you very much.